Hi everyone, good evening, and thank you for joining us for the Antenatal Shared Care Obstetrics update. My name is Lauren Thomas and I am a CPD Program Officer with Central and Eastern Sydney PHN. I also have Alex Woodowis, the Population Health and Chronic Disease Program Officer, who also looks after the RPA and Canterbury Antenatal Shared Care Program. Let's change slides. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and I pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples who may be joining us tonight. At the end of the webinar, we'll have an evaluation survey, which will be available from the chat and also a follow-up email. We'd really appreciate your feedback and it'll allow us to organise your certificates and RSCGP hours. So tonight's event has been RSCGP accredited for 1.5 hours of educational activity. To qualify, you obviously have to attend tonight's session in its entirety. We will also have a post-webinar activity, which will count for 1 hour measuring outcomes and 1 hour reviewing performance. And then we'll obviously submit those activity hours to RSCGP for you, and that will be sent out in the follow-up email as well. Please submit your questions in the Q&A box and we'll also get them answered during the session. Please note we may not be able to get to all the questions depending on how many we have coming through. We also have some upcoming events. Please visit the CESPN website to register. We have CPR, e-referrals, immunisation and data cleansing in general practice, which is a lunch and learn. And we also have our cultural awareness training that's coming up. If you'd like to register, the QR code is on the screen. And we'll have some more Antenatal Shared Care events available for April and May. These will be up on the website in the next few days. And just a quick reminder for any GPs in the Antenatal Shared Care program that we have that the 12 Antenatal Shared Care point requirement is for the training for the 2023 to 2025, but it's not annually like RSCGP is now. If you have any questions, please follow up and contact ANSC at cespn.com.au. And we've also got some hepatitis B information, which is on the screen. So there's a hepatitis B pathways to care project, and I'll also have some information for you that will also be sent out in the follow-up information. I would now like to introduce our GP facilitator for tonight, Dr. Rebecca South, who's one of the RPA and Canterbury and our Shared Care GP advisors, who will introduce tonight's speakers and facilitate the Q&A. So thank you, Rebecca.
Yeah, thanks a lot, Lauren. So thanks, everyone. Thanks for joining on a busy Thursday night. So I would like to introduce our first speaker for tonight that probably most of you know or have heard of or who have had letters back from or seen published works from, Associate Professor Glynis Ross, who is a visiting endocrinologist at the Royal Prince Alfred Hospital and who's been in charge of RPA's Hospital Diabetes and Pregnancy Service since 1991. And tonight, Associate Professor Ross is going to present to us on a very important topic which keeps changing and is so relevant to all of our practice in antenatal shared care, gestational diabetes diagnosis and management. So thanks.
Okay, thank you. Might help if I go back to the beginning. Hang on. Okay, so welcome everyone, and I will be trying to cover quite a few things in this update, but also hoping that it is going to give you some food for thought, even if it is an area that you feel fairly comfortable to be up to date with. So gestational diabetes in Australia has substantially increased in prevalence. And back in the 1990s, only about 3% of the pregnancy were affected by gestational diabetes. Change to the using, once the cure came in 1991, we had a substance up to 10 to 15%. And when we did change the diet process and criteria, in our area, it's sitting at around 18 to 20%. It's around 25% in Canterbury area. And around Australia, it's varying between 12 and 30%. Although one of the criteria, one of the reasons that the increase has occurred is due to the changing criteria, really the other factors are probably contributing more, which include ethnicity, maternal age, and maternal overweight and obesity. And I'll go through that with you shortly. So the data I'm showing in the next few slides is national data from the AIHW. It's readily available if you're interested in looking at it on their website. And so these are data now from the end of last year, but reflecting the previous couple of years. So the first thing you can see is the significant impact that maternal age has, the rates of gestational diabetes. And by the time women are 40 or above, the prevalence of GDM unrelated to other risk factors is already going to be up around the 25 to 35% level and substantially higher. We know also that there are other impacts, and remote and very remote tend to have higher rates, socioeconomic disadvantage, and the Indigenous population. And again, these data are available if you're wanting to look at them in more detail on the website. But really, one of the big impacts other than age for us is the country of birth. And again, these are national data showing the big impact from Southern and Central Asia. And certainly in the RPA area, we have had a significant increase in women from those countries over the last few years. And our Thursday morning clinic, where there are higher risk patients, tends to be particularly including a lot of women from Nepal, Tibet, etc. So the other one, which I'm sure you're very aware of, is the marked increase in obesity. And there was a LUM published in the MJA back in 2013, looking at the data up to 2010. So really quite old data now, but already showing that in rural Victoria, about 66% of pregnant women were either overweight or obese. And looking at broader national data, you can see that in the younger maternal age group, there was a big increase in rates of obesity, going from 3% up to 26%. And that was obesity with BMI over 30. And there was also an additional substantial increase in the women with overweight, and even higher rates and significant increase again in women in the older maternal age group. So why does gestation's point of view, hypertensive disorders of pregnancy, a slightly higher rate of caesarean delivery? National data show around 30% rates of caesarean overall, and about 38% for women with gestational diabetes, very much higher pre-existing diabetes than that. We know that the women are at much higher risk of cardiovascular disease. Baby's point of view, they're more likely to be larger babies. They slight increased risk of stillbirth and neonatal death, but only if the glycemia diabetes or if it's to the background population. Neonatal hyperglycemia is certainly a risk, and therefore risk.
Hi, sorry, Associate Professor Ross. Sorry, your audio's starting to cut out. Maybe if you turn your video off, it might
on
clear
the
up a little bit.
child, likely to have metabolic. Yep. Yes.
Hi, Associate Professor Ross, are you there?
Yes, I'm here. Yeah.
Yeah, sorry. Yeah, the audio was just becoming
Oh,
really
yeah, I think
unclear.
that was when I was turning off the video. So hopefully it'll
Yeah,
stay more stable. As
yeah.
I
So
said,
we've just
using
lost
my
your
remote
screen.
access because I didn't trust the home internet.
That's okay. We've just lost your
Okay.
screen as well with the
Can you see
slides.
it or no?
Not currently, no.
Okay, I'll have to go back.
Sorry. Thank you.
That's all right, not a problem. Can you see it now?
Yes, we can. Thank you very much.
Okay. All right. So mums who have had gestational diabetes are at higher risk of future cardiovascular disease, and that's even seen within the first 10 years after the pregnancy. We also know that these women are at risk of future cardiovascular disease, even if they have not developed abnormal glucose tolerance. So it's not only because of the diabetes, there is something extra that is occurring. Hopefully, everyone is familiar with the SLHD guidelines for diagnosing gestational diabetes. So this is the front page picture. If you're not, you need to let Laura know. We'll need to work out how to distribute these. So going through it in a bit more detail, basically we're separating out the very high risk factors and the moderate risk factors as determining when the women should be getting screened or tested initially for gestational diabetes. So the highest risk factors are having previously had gestational diabetes or any abnormal glucose tolerance, higher maternal age, particularly 40 plus, immediate family history and ethnicity, particularly South Asian. And I've already highlighted the reason for that. And then other factors such as class 2 or 3 obesity, previous large babies, polycystic ovary with hyperandrogenism, not just some cysts on the ovaries. And we've got the use of corticosteroids and antipsychotics, which will be problematic. Moderate risk factors are most other non-Caucasian ethnicities, maternal age 35 to 39, class 1 obesity, and again, any PCOS at that point. So as to how to test, just keep in mind, if you've got women on metformin for PCO or any other reason, to do a GTT, you really should stop the metformin at least 2 weeks beforehand so that you're not getting a medicated GTT, i.e. a modified one. So in first trimester, and we've defined that as under 12 weeks, we really would like very high-risk women to have a fasting glucose and preferably an HbA1c as well, rather than a GTT. And there are some questions as to how reliable the numbers are that we're using to diagnose GDM right at that very early part of pregnancy, because in early pregnancy, you're starting to get an expansion of blood volume and blood glucose levels over first trimester are going to drop by about 20%. So it is possible to overdiagnose if you're using 5.3, 5.4 as a cutoff in early pregnancy, or let alone the 5.1. So we're wanting to pick up women with clear-cut abnormal glucose tolerance at that point rather than the fine-tune. But if they have got high risk factors otherwise, and they're not already known to have some version of diabetes, at the moment we're recommending a GTT at 16 to 20 weeks. And if that is normal, then they should be getting tested around 26 to 28 weeks, as we would recommend for all women who are at lower risk. Please note that I did highlight on here that if not already known to have diabetes or GDM, because it's very frustrating when we see women who have already been managed just sent for a GTT, just because on the pathway it says to do a GTT at whatever stage of the pregnancy. And we've even had women with type 1 or type 2 occasionally given a form to go for a GTT, obviously highly inappropriate. And you might think, oh no, I would never do that, but clearly it has happened. We've also got on that form the issues about target weight gain in pregnancy, which I think all women, once they're pregnant, should be aware of what the recommended weight gain is for them according to their pre-pregnancy BMI. So as far as interpreting the results, so in first trimester, at the moment in our area health district, and also it's in the National Obstetric Guidelines, is that you diagnose GDM if the fasting is 6.1 or above, or the A1C is in a pre-diabetes range of 5.9 to 6.4%. And the higher category of diabetes mellitus in pregnancy is if they meet diagnostic criteria for diabetes outside pregnancy. So that would be a fasting glucose of 7.0 or above, and or an HbA1c of 6.5% or above. We don't need both, we just need one. And if any of these women are being diagnosed, please refer them very, very promptly to either Canterbury or RPA, depending on which is their area hospital, because they really do need to be seen quite quickly if they're being diagnosed so early. In second and third trimester, we're using the standard ADIPS/WHO criteria. So for GDM, the 5.1, 10 and 8.5 cutoffs. But if again, they meet diabetes criteria for outside pregnancy, again, they get the category of diabetes mellitus in pregnancy. And the reason for distinguishing the two is that if it's that top end, they really should be managed as for type 2 diabetes. Their pregnancies are at much higher risk. So again, we would like to see these women extremely promptly. So just an example of two women. So if we talk about Gina, 29 years old, Chinese ethnicity, it's her first pregnancy, and her father was diagnosed with type 2 diabetes at the age of 65 and is managed on metformin. He also has hypertension, but there's no other significant family history. Pre-pregnancy, her BMI was 21, and by 28 weeks, her weight gain has been 9 kilograms, which is quite appropriate for her pre-pregnancy BMI. And her GTT at 28 weeks was 4.3, 10.9, 8.6. So GDM diagnosed on the 1 and 2 hour readings. And not surprisingly, given how slim she is, the low fasting glucose. So she had a couple of risk factors with ethnicity and family history, but has done very well. So initial management for her is to talk to her about what gestational diabetes is, reassuring her that she hasn't done anything wrong, because a lot of the women think they've caused it, that there's something they've done wrong, but explaining, look, in late pregnancy, you need to be able to make about 3 times more insulin than you did pre-pregnancy. If your pancreas can't crank up the insulin production that much, unfortunately, the body does start struggling to cope, and explaining what the risk factors were for her. And these are things that she wouldn't have been able to do anything about. We do explain also, if they ask, that we really recommend all women, even if they've got no risk factors, to be tested, because we know that quite a number of them will also develop GDM. But in reality, most women these days do have at least one risk factor. And the reality is gestational diabetes is a spectrum. So the risks depend. Is it the glucose tolerance just beyond that for normal women, or is it right up near the pre-existing diabetes end? And the GTT itself, the levels on the GTT don't carry all of that level of risk. So you can't just be reassured, oh, look, it's just over, it may not be a problem. Certainly I find in the first few weeks of testing, you start picking up a lot of the women in whom the abnormality of their glucose tolerance is accelerating quite quickly. And we go through explaining that the main associations for most of the women are going to be that the babies may have some more accelerated growth, they may have some increased risk of high blood pressure, and that the babies, if we don't manage it well, may have more risk of low blood glucose after birth. So we then try and give them as much dietary support as we can. And at the moment, a lot of that is done, at least initially, in group sessions. And the general principles are having adequate carbohydrate for pregnancy needs, eating fairly regularly and avoiding very large meals at any one time. Again, general principles of low-fat nutritional balance, including adequate dairy. And we find a lot of the women these days are not having much dairy in their diet. Obviously, their diet, the dietary advice must be culturally appropriate. And there are a large number of NDSS resources, and some of those are in language, and certainly there are some for the most common cultures that we have in Australia at the moment, and these are being actively reviewed as well. We encourage the women to try to remain active unless there's an obstetric contraindication to that. We register them with the NDSS so that they can get access to subsidised strips, and we ask them to purchase a meter to do that. So just again, emphasising the importance of carbohydrates. Low carbohydrate diets in breastfeeding and in pregnancy must be avoided, and it's very easy to become ketotic, and if the carbohydrate restriction is severe in either of those settings, the women can get ketoacidotic. So it is a very strong risk, and they need adequate carbs for the baby, but we want lower glycemic index carbohydrates, so they need adequate information as to what that means. We do find that moving around for 10 to 15 minutes after a meal helps reduce the blood glucose peak, so that can be quite useful. We get very anxious if women suddenly start walking for an hour after every main meal, and that usually means that they're using up quite a bit of the extra energy that should be going to the baby. And unfortunately, if that goes to extreme, we can end up with some small babies, which we clearly do not want. And again, here again are the weight gain recommendations. So this is a sampling of the NDSS resources. There are videos, there are information documents, both simple sheets as well as booklets, and a number of these are in languages. So if you haven't ever looked at them, I would suggest that you get familiar so that you're able to recommend them as required for the women that you're seeing. So this is a sample of Gina's record when she first started testing. So apart from recording the glucose levels, we do encourage them to try to record their dietary intake, not just for communication with us for reviewing the dietary balance, but also so that it gives them an idea of what foods tend to work better or not. And that helps guide them as to which things they may need to modify. They will still need some input from us because we don't want them to over-restrict their carbohydrate intake because they're getting anxious about their numbers. So Gina in this pregnancy managed the diet very well. She was gaining further weight at the appropriate rate, didn't require any medication. Scan at 35 weeks showed appropriate proportional fetal growth. And she proceeded to a spontaneous vaginal delivery at 39 plus 3 weeks with a son of a healthy birth weight, and she was successfully able to breastfeed. And not particularly surprisingly for her, the glucose tolerance test at 4 months after delivery was quite normal. So that was a fairly straightforward pregnancy, and certainly the outcomes that we like to see. This is now a bit of a contrast. So Susie is age 41, Nepalese, pre-pregnancy BMI 32.6. Mum diagnosed relatively early with type 2 diabetes, and maternal grandmother also had diabetes. Susie's been trying for about 5 years for pregnancy, and she's come to see you for a referral to a fertility service for assessment and potentially asking, can I go for IVF? Clearly, she's at very high risk for diabetes, and really she needs this to be fully assessed before referring to a fertility service. Please don't refer a lady like Susie without assessing her first. So if she does actually have diabetes, and there is a reasonable chance she may, she needs diabetes-specific pre-pregnancy planning. And again, if you refer to the NDSS website, there is a checklist there which is available for the women. It's also useful for a communication sheet, and there's downloadable information for women about pre-pregnancy planning. We would also like her to be referred to a diabetes service at that point. She should be on high-dose folic acid, start monitoring, and then a decision made, does she need medication, which might be metformin, insulin, or both, but please no other diabetes medications in this setting. And there is a detailed ADIPS 2020 guideline for management of pre-existing diabetes in pregnancy that you can readily access on the website. If she has pre-diabetes rather than diabetes, she still would benefit from dietary assessment and advice, encourage increased activity, and aim for some weight loss before referring, but try and have a stable weight also before proceeding to pregnancy. And from my point of view, I would prefer a woman with pre-diabetes not to have a GTT in pregnancy, but just to get managed as gestational diabetes once she is pregnant. And from a legality point of view with registering with NDSS, that is actually allowed. As it turns out, Susie's GTT was consistent with diabetes, and indeed it would have been better for Susie to have had a fasting glucose prior to being sent for a GTT, as she would have been clearly diagnosed with GDM with a fasting glucose of 8.2, and would prefer women not to be getting glucose levels up into the high teens and 20s on the GTT. An A1C also could have been done, again, as that initial screen, and clearly 8.1% is consistent with diabetes. So she needs to be proceeding to all of these diabetes-specific pre-pregnancy assessments, as I've already gone through. And these were her glucose levels when she started monitoring, clearly very high. So she was commenced on a multiple daily insulin regimen. It would be okay to add some metformin as well. And we generally in pregnancy prefer, if metformin is used, to use the immediate release, not XR. Now, I'm sure a lot of you know I'm not that thrilled about metformin still at this stage in pregnancy. It does cross the placenta, and there is full exposure to the baby to the metformin. And I'll go through that again a little bit down the track. But again, in a pre-pregnancy setting, it is possible that I would use it for a lady like this, but then withdraw it at some stage through pregnancy. And we would then go through stabilizing this lady at reaching pre-pregnancy targets before sending her for IVF. I'm sure you're also aware of all of the advances that are happening in diabetes technology. And, you know, a lot of these are facilitating remote communication, which is good. There are some problems with some of the smart meters which have fixed insulin to carbohydrate ratios, because in pregnancy they're never going to work. The ratios keep changing. It's too difficult. Another comment on the interstitial glucose monitoring, because you know, a lot of women think, oh, this will be great. I hear about this. I'd rather just wear a device, not be pricking my finger all the time. In the setting of gestational diabetes, type 2 diabetes, I'm sure you know this is not subsidised at all by the Commonwealth, and it's only women with type 1 diabetes that get subsidy. So it's very expensive, and the cheapest system is the Libre 2, and it still costs $210 for 4 weeks. There is also not such clear evidence that it is going to improve outcomes relative to finger pricks, unlike the evidence that was available in type 1 pregnancies. But it can be considered. But if women do that, they really should be doing some finger pricking as well, because otherwise I find they get undermanaged. So this is just the sample of a Libre review report, if you're not used to looking at them. And since about October last year, instead of them having to actively scan and get intermittent readings, there's continuous readings now going through to the app. And you can see the rises, but it does tend to blur a bit, and there are lots and lots of numbers that appear on the reports, which can be a bit frustrating. So going back to the issue of medications other than insulin in pregnancy. So as I've already said, metformin does cross the placenta. Any woman on metformin should be having a B12 checked at least annually. And if you're starting metformin, I would check it at the beginning. It should absolutely not be used in pregnancy if there is any signal of a small baby or IUGR. It also has been shown to be less effective if a high fasting glucose, whereas you might think that might be the time when it works best. But if it is being used in pregnancy, it should be started and rapidly accelerated up to the maximum 2 grams per day. And if control is inadequate on that dose of metformin, insulin should be added. Clearly, if they can't tolerate that full dose, you can only give them the amount they can tolerate. The concern ultimately with metformin is that it may cause some programming with overweight in the infants, and that has been seen in the infants in the MIG study around the ages of 7 to 9. The pregnancy outcomes in women treated with metformin in the MIG study itself looked good, and the 2-year-old data didn't look particularly concerning, but by the ages of 7 to 9, there were signals that the children tended to have more body fat if they'd been exposed to metformin. So that's where there's some hesitation about using metformin until we get more confidence it may be safe. Glibenclamide, I really would advise against using. It absolutely crosses the placenta. There will be high rates of neonatal hypoglycemia, and the babies tend to be big because of the islet stimulation. Insulin, on the other hand, is safe. It doesn't cross the placenta. You can tailor it to whatever pattern the woman needs for her glucose levels. On some specific insulins, I personally don't like Optishilin in pregnancy, and find it quite difficult if you're trying to get to fasting glucose targets. The women tend to then be running into trouble with hypoglycemia later in the morning, and then you can't easily add a morning dose to try and control glucose levels pre-lunch and pre-dinner, whereas you can if you're using either Humulin, NPH, or Protophane. They're quite easy to use to tailor. And as I'm sure you're aware, Levemir is only under the PBS in Australia for type 1 diabetes. I do not like premixed insulins in pregnancy, as they are too difficult to tailor, and would only use them if it was a situation where I was unable to encourage the woman to use more injections than 1 or 2 a day. So from the baby's perspective, the offspring have about 8 times higher rates of developing prediabetes or diabetes by early adulthood, and much higher rates of metabolic syndrome and adult obesity. So in the postpartum period, obviously the women are encouraged and supported as best we can for breastfeeding. We try to give them advice on optimizing lifestyle, and it's important for the woman and the whole family, and try to encourage her not to gain weight over time, because it does accelerate progression to diabetes, particularly when there's been previous GDM. And we've published data from RPA that has shown that the women who have gained weight between pregnancies, which the majority of women do, have a much higher rate of GDM in subsequent pregnancies. Even though the women have just delivered, as for women with pre-existing diabetes, we strongly encourage them to plan future pregnancies, and they should have periodic glucose tolerance assessment, and there are some guidelines for that that would get sent to you through the NDSS for any women that have registered with them for GDM. And again, all in the longer term, really keeping an eye on all of the cardiovascular risk factors that you want to have optimized for the very long term to improve their cardiovascular risk. So as part of the GDM guideline that I showed you at the beginning in the SLHD, there are some guidelines for the postnatal follow-up. One of them is on frequency of doing the GTT. And for women who already have abnormal glucose tolerance postpartum, or if they're planning another pregnancy, we would suggest yearly GTTs. Otherwise, if they're not planning any more pregnancies, their GTT was normal, probably second yearly. Or once you're quite confident they're not going to have any more pregnancies, the general suggestion now is to do a combination of a fasting glucose and an HbA1c, but you need to be mindful that you don't just wait until those levels reach diabetes range. If they're starting to move towards pre-diabetes, you might wish to consider a GTT, which will be more sensitive at picking up very early diabetes. And as far as women proceeding to another pregnancy goes, if they've had GDM, really try and encourage them to plan the next pregnancy. Come and see you beforehand, have their glucose tolerance assessed, check when they were last assessed, do they need a test ahead of time, how are they going with their weight, how are they going with their diet, their activity, and try and encourage them to optimize everything again ahead of another pregnancy. You'll be able to get access to this. It's not easy to really go through this in detail on the slides, but I'm providing it to anyone who wants it. So one of the suggestions has been, when you're trying to follow up women who have had GDM, trying to sort them out into, are they very low risk, medium risk, or high risk, as to how aggressive you need to be with follow-up and which testing to do. So clearly, if all of the parameters, their glucose tolerance, their weight, their lipids, their blood pressure, and abdominal circumference are okay, then they're going to be at low risk in the over the next few years. Whereas as those risk factors become abnormal, you need to be much more alert to following them up and be worried that they may progress to diabetes quite quickly. So to sum up, gestational diabetes is associated with increased risk of short and long-term adverse outcomes for the mum and baby. GDM has been continuing to increase in prevalence, but I've left this to the last. There is going to be a review at some stage in the next few months. There's going to be a summit meeting of a range of practitioners and people with interest in the area to review the current diagnostic criteria and pathway in Australia. So there may be some modification occurring in the next 12 months. So be aware of that. Ideally, I would prefer all women to plan all pregnancies and for them to come and see you and have an assessment of their risk factors for GDM. Do they need assessment pre-pregnancy? And guiding them beforehand, particularly when they're at high risk, on appropriate nutrition for the pregnancy, what their appropriate weight gain is going to be, what exercise they need to be, and being very, very mindful of all of the impacts of their culture on their expectations and their supports that are going to occur for this. Long term, you really do need to follow up these women and have a system in place to review them periodically and give them all the support they need when they're trying to juggle, you know, young family, which gradually grows up and not reducing in demands on them, work and other family commitments, which can be parents, parents-in-law, etc. as well, as you know. And we don't know what exactly to advise, but the offspring of diabetic pregnancies also will need to be flagged for longer-term follow-up. So that's the end of that, and I hope you've heard more of it than not. And I'm happy to answer any questions that have come through, and I'll just close down the screen.
Well, thanks so much, Glynis. That was, I certainly, yeah, learnt a lot. There were a few little glitches, so
yeah, I gathered.
So if people can just post questions in the Q&A, because unfortunately my Q&A kind of got a bit cleared along the way, so somebody might have posted some questions that I didn't get to see. But there was a question that came through about why emphasize dairy. What's the particular importance of that in terms of...
It's nutritional balance. So so one of the things that has been shown to increase hypertension rate is low dietary calcium. So it tends to get assumed in Australia that, you know, most women are going to have adequate calcium and you don't need to worry about that. But if you look at guidelines of that have come from studies looking at do calcium supplements help reduce rates of hypertension in pregnancy, it only seems to have benefit if there's low calcium diet. But reality, if you actually survey women as to how much dairy they're having in their diet, and if you don't have much dairy, you're not likely to be getting calcium from other sources without supplement. Most of them are really restricting their dairy, and a lot do it to try thinking that that will help them lose weight. So it is something that's important to do and not assume that all women have adequate dairy or dietary calcium.
Yeah. And another question has come through, which is quite interesting. So there's a statement made that breastfeeding for 6 months actually can significantly reduce the risk of the woman herself developing diabetes.
It's good for the woman and good for the baby.
So is that incorporated as part of antenatal education for
Yes, so
women?
Yeah, so there are breastfeeding classes that the women are certainly encouraged to go to, and we really do encourage the women to try breastfeeding.
Yeah.
I think it's very strongly encouraged at RPA, to be perfectly honest. Sometimes a bit too much.
Sometimes too much, yeah. A good question from Effie. In general terms, how do you work around fasting for Ramadan?
That's I'm having spent a large part of my life also working at Lick and Bankstown. I've been very familiar with this area for a very, very long time. So it's difficult. So certainly and we've actually looked into this very carefully, both officially and unofficially with the imams, and we've Sarah Abdo from Bankstown, wrote a very good article and advice for women. And if anyone wants it, I can provide copies of that. So, and Sarah understands it because that's her background. So basically, women who are pregnant are not expected to fast. And we try to encourage them, and a lot of the women don't, and that's accepted. The problem is it's such a social event that a lot of the women choose to because of the social side. And it is really difficult because both with gestational diabetes and any version of diabetes in or out of pregnancy, it does pose issues. But all we can do is try and encourage them to eat adequately. The problem is with the feasting, it's just as bad as the fasting. And at this stage of the year where it's starting in the hotter weather, the days are longer. And so that actually has more problems for fasting. And it's going to be worse for the next 4 years because it's progressively coming more and more into some with long days. So we would counsel them and say we would prefer them to not fast, and that's, they can go and talk to the Emma about it. They don't have to take our advice if they don't trust us, but we would prefer them not to. If they choose to, they just need to try and do the best they can with managing their diet, but it's difficult. There's not going to be an easy answer.
Yeah.
But we have sought proper advice on that one. Yeah.
On that one. Yeah. So in terms of, questions come through about managing people who get vomiting after they try the glucose tolerance test.
The GTT, okay.
The 75-gram GTT, and how would you advise that GPs kind of approach that?
Okay, I'll just give one
antiemetic, or do we?
Okay, so number one, if they've had bariatric surgery, absolutely, please do not send anyone for a GTT. You just have to do fasting glucose and an HbA1c, and they can, do some monitoring on finger prick, but keep in mind if they're not diagnosed with diabetes, the strips won't be subsidised, so they'll be $80-something plus a metre. But absolutely do not send women who have had gastric sleep. They will be at high risk of dumping syndrome, and that's a strong recommendation. And we've actually got close to final a new guideline on this. So it's, we've got to get it through their final hurdles of the process, but it should be available in the next couple of months. So that'll be a broad guideline for our area. Okay, so that's one big thing to remember. We do not want them to be sent at all. The second thing is if they do vomit, it's difficult. The women will be resistant to having a test. So it's trying to cajole them. Things that help reduce it, you can give them Maxilon, so metoclopramide. Please don't give ondansetron. It does improve glucose tolerance, which means you may miss GDM with ondansetron. So it should be Maxilon or metoclopramide. It is best if they have a very cold, like the drink is actually chilled. That makes it easier to tolerate. And it's best if it's possible at the collecting centre to have a reclining chair. So at RPA, we don't do routine GTTs at the metabolic unit, but we can do them for women who have vomited in a GTT. So it's contacting, we do it through the metabolic service, and they have got the recliner chairs, and we make sure that they were given some metoclopramide to do that. In obviously the private places, that's highly unlikely that they will get given a recliner chair.
And just with metoclopramide, is it better for us if we're in a position to be able to do it, like a lot of practices do actually have on-site pathology? Is it better to use the Maxilon IMI, or is oral?
We haven't got any evidence that either makes a difference. So, yeah.
Okay. Cool. Yeah. Some questions about ideal kind of exercise. What you'd advise. You've mentioned about the postprandial exercise.
Yeah, so it obviously depends a bit on what exercise the women were doing pre-pregnancy. So if they're very fit, they can maintain ongoing exercise at what level of fitness they were doing. The reality is most women aren't doing that. So the best exercises really are going to be walking or swimming, again, depending on what they're used to doing. It's encouraged for all women who are pregnant, not just related to the diabetes, that they try and do some degree of exercise that's appropriate and not stressing them. And clearly, one of the advantages of swimming is you've got the buoyancy and the coolness compared to, especially in summer months, compared to walking and sweating. But we just don't want them to suddenly, if they've not been exercising, to suddenly start going to an extreme. So that's the big issue. But we do find that particularly, like, you probably know, we do 1 hour post-meal readings. The fasting glucose and the 1 hour glucose are the readings that have been strongly associated with baby outcomes, much more than a 2 hour reading, which is the reason we do the fasting and 1 hour at PA. I know other sites do 2 hour, but the evidence for that is much lighter. We find that if they do moving around in that lead up to when they're going to do the finger prick test, that the glucose just tends to curve over a little bit. And it's when you've got exercising muscle, it can take up extra glucose without needing more insulin. So that's the reason behind it. So, if you've got women who are working at a desk at lunchtime and they're trying to just get through the work so they can get away early, or they're busy, it's better if they get up and move around and they can just find something to do. You don't have to go for a formal walk. You can just be moving around because you've got your muscles firing at that point. Yeah. So we just try and encourage them to be moving around a bit after a meal, and 10 to 15 minutes is heaps after the meals. Yeah.
Right. Yeah. No, I think that's really good advice.
And easily achievable for the women. Yeah, it's easy. They can, if they're at home, they can just find a few things to do, moving around, do the washing. Bring the washing.
There's always plenty of stuff to do. Look, that's been great. Thank you so much. We have got more questions, but we have to move on to the next speaker. But thank you so much.
Well, anyone can contact me. They know how to find me at PA, and the slides, if they couldn't hear, they're welcome to have the slides through Lauren. So that's okay.
Excellent. Okay. Thanks so much for this. We'll see you again, I'm sure, because we love having you come to speak to us.
Okay. Thanks. No problem. Okay. Bye.
Thanks. Bye. And our final speaker for tonight is Dr. Ying Li, and he's an accredited fertility specialist with Genea, with consulting rooms in Sydney CBD, Hurstville and Walleye Creek. And after completing specialisation in obstetrics and gynecology, Ying has completed further training as a subspecialist in reproductive endocrinology and infertility. So thanks so much, Ying, for coming to speak to us tonight. I'm sure everyone will have lots of questions about fertility and things as well, including questions about metformin, possibly.
Thank you, Rebecca. Glynis is a very hard act to follow, but I will do my absolute best. So I'm just going to try and share my screen. We did work on this before and it did work. So hopefully just bear with me. So yes, as Rebecca said, I'm a fertility specialist and a subspecialist in reproductive endocrinology and infertility, or CREI, at Royal Prince Alfred Hospital and at Genea Fertility as well. And I think the aims of this talk, I just want to give everyone just a brief introduction into what it is like to do a fertility screen, how to assess couples, and then use a few cases to outline some of these concepts. By no means is this supposed to be comprehensive, but happy to answer any questions afterwards. So infertility has traditionally been defined, and this is still the WHO definition, as sort of 1 to 2 years of unprotected intercourse without sexual conception. And that's based on sort of population data that really says that if a couple has regular intercourse, then 85% of those couples will, after a year, achieve some sort of pregnancy. And if you look at the remaining sort of 15% of couples who then keep trying for another year, then half of those couples should then achieve a pregnancy. So that means roughly 92 to 93% of couples after 2 years of trying really should be achieving a form of pregnancy, whether this is an ongoing pregnancy, live birth, ectopic, miscarriage, and so forth. Only late last year, the definition has actually been extended. This is worldwide, but has been led by the Americans at with the sort of ASRM Congress, and they've now said that really infertility should cover anybody who's having trouble falling pregnant, based on a clinical assessment, and anybody who needs medical intervention to achieve a pregnancy. And this is significant because it does actually then put a lot of our sort of LGBTIQ sort of population in the mix so they can actually access fertility treatment and have it on Medicare. We think based on the traditional definition, the prevalence is about 15%. With this new definition, it's probably a bit higher. I'm going to talk a little bit about age because this is the big elephant in the room when we talk about fertility. And it's just, you can't escape this, unfortunately. With age comes a decrease in both egg quality and egg quantity, and therefore a decrease in the ability to fall pregnant. So really, as you can see, human beings are not really that fertile from the very beginning, and that is only a declining statistic, but that decline is fairly steady until a woman hits about 37, 38, and that decline is quite steep. And really, when a woman turns 40, both with IVF pregnancy or traditional IVF and also with spontaneous pregnancies, their take-home baby rate is really about 10%. In terms of causes, I mean, there is such huge range in these figures because different studies say different things, but we like to say roughly a third, a third, a third. So a third male, a third female, and a third either unexplained or combined. Before screening anybody for fertility, I think it's important to assess for suitability of pregnancy. Certainly, we do a lot of these assessments, and we do this in conjunction with our colleagues at the Medical Obstetric Clinic. It includes a general health assessment, and certainly all of our older patients, so patients aren't over the age of 45 who are using donor eggs or looking at using embryos that they had previously stored in the unit, they get a cardiology assessment as well. A prenatal screen, as you all know, is very important, and I'm sure Glynis would have said, assessing their glucose tolerance is also very, very important. I'm going to talk a little bit about what determines fertility, and based on these sort of concepts, we then look at how each factor can be tested or investigated. To achieve fertility, there needs to be adequate communication between the brain, so both the hypothalamus with the pituitary and also the ovaries and testicles. There needs to, of course, be the presence of gametes. There need to be gametes there, eggs or sperm, and these eggs or sperm need to have a way of being released. The quality of the gametes themselves do influence the quality of the embryo and therefore the success of that pregnancy. The embryo then needs to be successfully able to implant into the uterine lining, and overall the genital tract also obviously needs to be intact for that to happen. And there are other determinants such as other medical conditions. History and examination, you'll know this. In the female, we are interested in things like age, parity, menstrual history. Menstrual history is actually a really good determinant of whether they're ovulating or not. And I hardly ever do a day 21 progesterone. We'll talk a little bit about that later. Other medical conditions such as endometriosis, family history, especially with the advent of the government offering sort of carrier screening as part of Medicare. This has become increasingly important. Functional issues, sexual function, and of course, medical, social background and social background. Very similar for males. So age, previous paternity. Age is a determinant for fertility in males. The quality, while the gametes, the sperm is present in older male and present in males until they die. The quality of those gametes, the quality of that sperm does drop quite significantly. And of course, all the others, family history, surgical history, and social history is really important. So if we talk about the hypothalamic pituitary gonadal axis, I'm sure you guys know this diagram, but essentially the hypothalamus releases gonadotropin releasing hormone. This then communicates with the anterior pituitary, which will release follicular stimulating hormone and luteinizing hormone. This will then travel in the bloodstream and come and communicate with the ovary and the testes themselves. and the gonads will release either estrogens or testosterone plus inhibin, and they will then negatively feed back on both the pituitary and the hypothalamus. And this is certainly a very elegant sort of axis we talk about. We know the reality, however, is a little bit more complicated. So this is talking about higher center controls on the hypothalamus. So we talk about the hypothalamic pituitary gonadal axis, but really we now know there is a loss of control above the hypothalamus that determines gonadotropin releasing hormone release, and therefore FSH and LH pulsatility. Some of that also comes from peripheral hormones. As you can see, insulin, leptin, and ghrelin, much interested lately in terms of sort of all the bariatric medicine that's happening. All of this can affect the competence of the hypothalamic pituitary gonadal axis. How do we measure this axis? So I'm just really going to talk about females really in this talk, but it's a straightforward axis: FSH, LH, and estradiol, and if you like, add a progesterone as well. It would be helpful to know in which part of the cycle the person is in when they do this. Probably the most accurate time to do this is in the sort of the first 2 to 3 days of their menstrual period, but sometimes that's not possible. It's really difficult to interpret an estrogen level or estradiol level alone without FSH and LH, so that they really should be done together. In addition to this, we do suggest adding thyroid function tests, TSH, T3, and T4. This is contentious. As an IVF specialist, I do this because we do think that elevated TSH does affect our fertility outcomes, but the ATA, the American Thyroid Association guidelines are very much sort of in equipoise about this. Okay, then let's talk about ovarian reserve, and in terms of how do we measure ovarian reserve and what is the natural physiology. This is the graph I show a lot of people, and it's one of the more depressing graphs that we have. Female ovarian reserve will only drop and they will never increase. So the peak of ovarian reserve actually was when a female fetus is about 20 weeks. At that time, they have about 4 to 6 million oogonia, so each premature oocytes, which then drop to about 1 million when a female infant is born. When a person undergoes her first period, that number is already down to about 500,000. And as you can see from this graph, it just gradually declines. And when the overall oocyte number in the ovaries reach less than 1,000, and we think this number is fairly consistent, then menopause happens. Now, whether that comes naturally because of just menopause and aging, or whether that comes through surgery, chemotoxicity, like chemotherapy. There have traditionally been a lot of ovarian reserve tests: day 3 FSH, day 3 E2. Clomiphene challenge is never used now. Antral follicle count and AMH levels are the two that are really used. But you will see some day 3 FSH. You can do them as part of your axis measuring device. We do see in people who have depleted ovarian reserve, there is a marked drop even on day 3 of estradiol levels and inhibin B, which means that there is loss of feedback, negative inhibition into the pituitary. So we do get a significant rise in FSH without such notable rise in LH. And we really do say anyone with an FSH level on day 3, if their periods are regular, of about 10 to 15 international units, is really abnormal. That number correlates well with how well they will do in IVF. But there is some cycle-to-cycle variability to this. But somebody who has consistently high FSH, this is a poor prognostic factor for fertility treatment in the future. At day 3 E2, they really come in hand with day 3 FSH, but it's less reliable. It seems to correlate poorly with things like ovarian reserve. So we always do the two together, but I have to say I pay more attention to the FSH and the E2 at this stage. Okay, let's talk about antral follicle count. Antral follicle count is an ultrasound test. The number of follicles measured must be less than 11 millimeters, and the ideal measurement for a time in which they should be measured will be in the follicular phase. Certainly, normal is highly varied, and there is disagreement on whether 3 to 10 is considered normal, whether it's in one ovary or it's in both ovaries. So there is some subjectivity to this measurement or interpretation of this measurement. It's certainly better than AMH. We think as a measure of response to ART or IVF, it is probably the equivalent of AMH, but better than FSH. However, it's not really associated in itself with any sort of live birth outcomes. It is, of course, very operator dependent, as you can see on this diagram. Depends on where you take the slice of the ovary, where you screenshot. There is actually no standardization. In Australia, we're very lucky to say that most of our practitioners in ultrasound will insist on a day 3, day 1 to day 5, really, a antral follicle count. But even then, there is sort of inter-cycle variability. So you could have a good cycle where more follicles are activated, so where the AFC is quite high, and you can follow by a bad cycle. So there is that to consider. Okay, anti-Mullerian hormone, AMH. I'm sure you guys do a lot of ordering with this. This has garnered a lot of press, and patients will Google this and they will know about it. AMH is a member of the tissue transformed growth beta superfamily. There's a whole group of these hormones. It's coded on chromosome 19 for the hormone, and its receptor is coded on chromosome 12. And importantly, it is actually produced by the granulosal cells of the follicle, but it is not produced by the oocyte itself. So it is produced by the cells of the follicle. AMH is only produced also by what we think are small pre-antral follicles and also small antral follicles. But really, after a follicle reaches about 12 to 13 millimeters, AMH is not really produced at all. And we think the time that AMH is produced up to is when a follicle reaches about 10, 11 millimeters. And that means at the time when we do an antral follicle count. AMH does have a function. It's an inhibitory hormone, and we think what it does is that it stops primordial follicles from being recruited and being activated by the ovary. So it actually has a really important role in suppressing the follicles from all waking up at the same time. And what we see happening in some chemotherapy patients, especially when they have treatments involving the alkylating agents, so cyclophosphamide is the really key one, is that the drop in AMH leads to massive recruitment of dormant follicles, especially when they're undergoing chemo, and these follicles then die, and by the time they finish chemo, there is actually no more underlying pool to recruit from. What we also think it does is that it has a role in dominance, so it actually suppresses the receptors, the expression of receptors to FSH as a cycle continues, and that means that only the dominant follicle, which is less sensitive to AMH, can actually respond to FSH. AMH, we think, has a trimodal peak. This is important because if you measure an AMH level in somebody who's 18, 19, 20, we know they're probably not at their peak. And it's really tricky when we see sort of people who have had surgery, who are young, or who've had chemotherapy, and who come to us with low AMHs. And we know the AMH peaks around 25, 26. So it's really hard to determine when somebody comes through who's in an adolescent comes to us with an AMH which is low, whether they're actually just on the way up, or this is truly a measurement of decrease of ovarian reserve. But what does AMH actually measure? AMH is a measure of quantity. There are lots of studies that are trying to correlate AMH with oocyte quality, and none of those studies have shown that to be convincing. It seems to have correlate really well to response to IVF. It correlates well with whether the ovary has suffered some sort of trauma. I have had patients who have come to us who it's demonstrated beautifully in that they have a pre-surgery AMH, and then they go on and have a cystectomy or an endometrioma removed from a private unit, and we remeasure the AMH, and that AMH has more than half. So it's really a good measurement of what has happened to the ovary. Compared to all the other tests that we've seen so far, there is certainly less individual variation and cycle variation compared to everything else, but it still exists. So we do see this. And one of the things we see most commonly is the pill. We used to say that the pill drops AMH about 10-15%. It probably drops it more artificially. Roughly anything under 14 picomoles is consistent with folding ovarian reserves. Anything over 30 is probably consistent with PCOS and risk of OHSS. That number has changed a bit, but the latest PCOS guidelines do reflect the fact that AMH can be used as now a diagnostic marker for polycystic ovarian syndrome. But this is not all, not all good news. As we said, there is intracycle variability. We know AMH is higher if you measure it in the first half of the cycle compared to the second half of the cycle. We know there is intercycle variability. And it's important to understand that given that AMH is measured is released only by follicles that have been recruited, it is really an indirect measure of ovarian reserve. And what I mean by that is the ovary will recruit or wake up eggs each month based on how many eggs there are in total or underlying ovarian reserve. The more oocytes it wakes up, the more AMH those follicles produce, and therefore it's actually an indirect inference, I should say, to ovarian reserve. There are some lab issues, but those lab issues are getting resolved more and more these days, and it's really important to state to patients that AMH is not a reflection of fertility. It says nothing to us about oocyte quality. We have people with very low AMHs, and they will fall pregnant. Okay, so that's sort of female gamete quantity. What about male gamete quantity? Semen analysis, really easy to do. For those of us in the area, so DHM and all the other labs will do it for free. But Concord Andrology also will do this for bulk building. We certainly send all of our publications to Concord Andrology. The semen analysis standardized guidelines have actually been updated in 2021. There isn't a huge amount of change, I have to say, as you can see from this table. But we use the 2021 guidelines purely because it's more of a pan-ethnic population of normal semen parameters, whereas the 2010 guidelines were mainly sort of Northern European populations. Okay, how do we assess ovulation? And I have to say, the traditional method of day 21 progesterone, I think I don't really order. I think clinical history is probably the most important factor in assessing whether somebody is ovulating or not ovulating. As you know, if they're not on the pill, if they have really regular clockwork cycles, then it's very unlikely that have an ovulation disorder, purely because the corpus luteum is absolutely necessary to regulate your period. A day 21 progesterone can be done in people who have regular 28-day cycles, but then, as I said, if somebody has a regular 28-day cycles, they're probably ovulating. If somebody has really irregular cycles, then what we're looking for is mid-luteal progesterone, and a day 21 progesterone is probably not going to be mid-luteal, so you may miss the ovulation, you may miss the progesterone rise as if they ovulate later. The basal body temperature change, it depends on your instrument that you're using. LH urine you can, but keep in mind that LH only occurs very transiently in the urine. I have to say the most accurate measurement of ovulation is to do ovulation tracking by blood tests. All the major IVF companies will do this now for bulk build. So Janaea, IVF Australia, and Monash, they will all do bulk build ovulation tracking. In terms of, just want to update everybody about the new ovulatory disorder classification. So for ages, we've been using the WHO Axis 1, 2, 3, and 4 classification. This has recently changed, so they now have a HIPOP classification, which sort of grades it whether this is a hypothalamic problem, or whether this is a pituitary problem, or whether this is an ovarian problem. And polycystic ovarian syndrome, given that it encompasses so much, gets its own classification as category 4. Then in terms of causes, they use this mnemonic called gain fit pi, which I always found very strange. It's just like when they did their mnemonic for abnormal uterine bleeding called palm coin. But essentially they're saying in the hypothalamus, there are genetic autoimmune iatrogenic and neoplastic reasons for why the hypothalamus is dysfunctional. And they're looking at functional infectious/inflammatory reasons in the pituitary plus trauma vascular. And in the ovary itself, this idiopathic, physiological, and endocrine. So that is now the classification we're going by. Can we assess gamete quality? Really, really difficult to do indirectly. There are, really difficult to do directly, I should say. There are indirect markers. You can look at karyotypes to see whether you're potentially making aneuploid gametes. You can look at whether they have endometriosis, which may indicate that they will affect negatively the quality of the gametes, but really the best measure of a gamete's quality is what kind of embryos they make, whether it's in the lab like in IVF or whether they get a successful pregnancy or not. What about looking at the structure of the genital tract? I think this is all familiar with people. HSG is an X-ray test. It is offered at multiple radiation places, and RPA radiology will do this as well. It gives really good information about the shape of the cavity, and it's good for proximal obstructions in the fallopian tubes. And if it's successful goes into the tube, you get an outline of the mucosa of the tubes as well. It is, however, quite painful. There is a rate of infection, and you don't get any information about things like the myometrium in the ovaries. Ultrasound is probably our first line. The images are good. The tubes really aren't seen if the tubes are normal. You can extend this one step further by using a hycosi, which gives really crisp, clean images of the uterus. It's really good for things like fibroids, especially submucosal fibroids, because these are the fibroids that we know affect fertility. They can do a 3D reconstruction for Müllerian defects, and they can also, and ultrasound in general also looks at all the other genital tract structures. There are, especially in hycoses, there are infection risks. There are false negative with hycoses, purely because you can get salpingospasm where the tubes will spasm from pain, and you get a pseudo blockage, and it doesn't really outline the mucosa of the tubes as the HSG does. You can see here, so very clear on the left, this is a 3D reconstruction of just a normal pelvic ultrasound, and these images are courtesy of Ultrasound Care. So on the left, this is very clear. This is a bicornuate uterus, so two cavities. So this is what we call a fusion defect. So this is where the two Müllerian ducts have fused at the bottom, at the distal end, but they have not fused at the top. And on the right, you can see this is an HSG. The bright white is actually saline contrast. And you can see it spilling into the cavity. So this is a patient fallopian tube, but you can't actually see the tube itself. What structural pathologies are we really caring about? So I suppose fibroids is a big one. Polyps are extremely common, though I have to say the role of polyps in infertility is extremely debatable and extremely controversial. Depending on what studies you read, they're very bad or they're very good, or they make no difference. I have to say our practice is to remove them purely because of the small rates of dysplasia or hyperplasia if you leave them long enough, and also the sort of low risk intervention that is to remove polyp. Fibroids, anything that distorts the cavity affects fertility, and these are mainly in the submucosal fibroids. Asherman syndrome or uterine synechia are definitely affecting fertility negatively, and I seem to be going through a run of them at the moment. So in fact, we've done over 3 or 4 sort of Asherman's resections lately in the last month, which is quite a lot. More common in people who've had multiple uterine traumas like DNCs. Uterine septum is very controversial. We think that the septum causes an area of abnormal vascularization in the uterus where it forms, and therefore it negatively impacts on the ability of the embryo to implant. this has really never been sort of proven with RCTs. Certainly in idiopathic infertility, there's probably much more evidence of this in the recurrent pregnancy loss scene. And as you can see from other Müllerian duct abnormalities like bicornuate uteruses and didelphics. Any other imaging modalities? Imaging the uterus, the gold standard is still hysteroscopy and laparoscopy. That is still the gold standard. Now, it's not saying that everyone should have this because this is extremely invasive, but I suppose when there is doubt in any of the imaging and if we think it's irrelevant, either having a hysteroscopy and/or a laparoscopy will clarify this. So I'm just going to summarize all the investigations. I know sort of there's been a lot of slides, but really in the female, we would recommend at a sort of a general practice level, a prenatal screen, a decent pelvic ultrasound, a hormone profile looking at the hypothalamus pituitary and gonad axis, so FSH, LH, E2, progesterone, and some TFTs. And what's really optional is AMH, only optional because they have to pay. And I suppose if you get a good angio follicle scan, you know, the effects are equivocal. Karyotype is also optional because they will have to pay. It does, I have to say, I routinely do a karyotype, but purely because patients come to me really for IVF. And a day 21 progesterone is an optional purely because I think it's a little bit unreliable. In terms of males, we do ask for a basic serology, Hep B, Hep C, HIV, syphilis. Semen analysis is obviously the thing we want, and the karyotype, again, optional. So there's sort of all of my more sort of didactic slides, and I sort of just want to follow on with just two case studies that illustrate some of these concepts and probably introduce a few other new ones, hopefully. So this is a case one of primary infertility, and this is a young couple who've been trying, well, female, who's been trying for a couple of years. So she's a 32-year-old P0000. She has fairly regular cycles with normal pubertal development, having regular intercourse. She's got no symptoms suggestive of endometriosis, no medical background. She's got a family history that everyone is really fertile. She's a teacher, doesn't smoke, drink, or take any recreational drugs. She exercises moderately, and I have to say, this is one of those things we do emphasize in patients who are trying to fall pregnant. Moderate exercise, 30 minutes of aerobic exercise 5 times a day for people who are of normal weight is more than enough. 5 times a week. In terms of the male, so he was 39 years old. He's got no previous paternity. He's got no real history of significant testicular trauma. His testicles develop normally. He's well virilized. He has normal puberty. No significant medical or surgical background. He's got no family history. He's been a chef for 20 years. He smokes. He doesn't smoke or drink. He doesn't exercise because he does shift work. So I just saw this patient. I thought, well, it should be okay. And her stuff was all fine. He came back really on 2 samples of quite surprising azoospermia. So he had no sperm. There was volume, so there was semen, but there was certainly no sperm, and their karyotypes, both of them are normal. So I think I saw this couple and I was a little bit puzzled. So I did what I normally did, and did like a hormone profile, which showed that he's got low testosterone, FSH, and LH, which indicates that there is something going on in the testicle itself rather than anything else. We did a cystic fibrosis screens to look for absence of vas deferens, and he was negative for that screen. We did a Y microdeletion test to look at genes that code for spermatogenesis, and that was all fine. And then I sort of delved a little bit with him about his work history, and it turned out, and when we talked about stove height, the stove that he used was actually quite low. Sort of just below the umbilicus, and he's been standing in that same kitchen for over 20 years, and it gets quite hot. And we couldn't find anything else, and I think we came to the conclusion that this was just decades of intense, prolonged exposure to heat, which caused this azoospermia, which we know can happen, but I suppose you really wouldn't sort of think about it if you didn't delve a little bit more into the history. So we said that this was a case of non-obstructive azoospermia with presumptive causes testicular damage from the prolonged heat exposure. So the only treatment for that is IVF. So she underwent a cycle of IVF. She did quite well, as you can expect. We also then, at the same time as the oocyte retrieval, we did something called a microscopic testicular dissection. So this is something that we will do in theatre at RPA, but it can be done in day surgery in Geneva. So at the time of the oocyte collection, the male undergoes a general anesthetic, and they essentially have their testicles bivalved by us, and we bring in an operating microscope, and we actually use the microscope to look at the seminiferous tubules. We have a scientist with us, and we essentially biopsy different tubules until we can see a tubule that contains sperm. So this is from a textbook. This is a really good example, but you can see here in the middle, there is a clump of tubules that are actually really quite opaque in nature. They're creamy and white. They're really thick, whereas surrounding tubules, they look like thin strands. These ones down here, they're certainly more translucent, so more glassy-like, more hyalinized. And therefore, it's very clear that this is the area of spermatogenesis that remains in this testicle, and we harvested those tubules, and this was the case with this man. We got a few areas that were making sperm, but the rest of the testicle was not, and we got some sperm for use, and they also had enough to store. So using that micro-dissected sperm, we were able to create 7 embryos. These guys froze all the embryos for some aneuploid screening. We transferred one of those back, and she fell pregnant and had a live birth. So quite a nice story, but really illustrating the fact that history is really important, especially for these unexpected findings. Following up from that, I did refer him to an andrologist. So the andrologist unit at Concord really is excellent. They're run by a group of endocrinologists who have an interest in this area. And really, this guy needs lifelong testosterone replacement therapy, which is what he's getting. So, case 2 is a case of primary infertility and pelvic pain. So again, fairly young couple, both 35, been trying for a year. Regular intercourse, she has regular cycles, but quite severe dysmenorrhea and dyspareunia. She's a non-smoker, no family history. She's a dancer, has a BMI of 21, which is healthy, no other background, keen to keep trying naturally, but was referred by the GP for consideration of IVF. He is 35 years old, really unremarkable history, works in finance, really sort of clean living. Their investigations are completely normal. She has a really healthy ovarian reserve, normal thyroid function, normal hormones. The uterus is normal, it's anteverted, but it did note that on TV scanning, she was quite tender. The male has a normal serology, normal semen, and normal karyotype. I remember having a chat to her about her options. She was quite keen to avoid IVF, and we did point out that this is possibly endometriosis. We talked about her options of, even if this is endometriosis, would it go down an IVF pathway to a few cycles of IVF? If that's successful, then that's it. But if not, then we move on to surgery, or we go the other way around. Given that she was sort of in pain and keen to do this as naturally as possible, we decided on surgery. We would do a resection if there's endometriosis, and then they would try naturally for 6 months afterwards, and not pregnant, we would move on to IVF. So at the laparoscopy, we always do a laparoscopy and a hysteroscopy while they're asleep to look at the cavity of the uterus. The hysteroscopy was normal. The laparoscopy, interestingly, showed ASRM stage 3 endometriosis with normal fallopian tubes and ovaries, significant pelvic sidewall disease bilaterally, and also nodular disease in the sort of thick disease in the sacral, uterus sacral ligaments bilaterally. We did something called an endometriosis fertility index score, or an EFI, and I have a nomogram of that sort of on the right here. This is a measure of classifying endometriosis according to the prognosis for pregnancy and fertility. So this is to say, if you find endometriosis in surgery and you treat that endometriosis, what is the likelihood across time that this woman can achieve an ongoing pregnancy? It's based on the severity of the disease and what they call a least function score, which is look at physical anatomical distortions of the fallopian tubes and ovaries. And also based on a few clinical history like previous parity, age, and so forth. Because she had disease, but there was no real anatomical distortion, she actually fell on the green line. She had an EFI of about 7 to 8, which is really high. Oh, sorry. And which meant that she actually has a quite good chance of spontaneous of ongoing pregnancy after surgery. And you can see that line goes up and up. And it's important because we traditionally used to say that if you have endometriosis, you really have about a 12-month window to have an increased rate of pregnancy, and after 12 months, that increased rate actually plateaus. And that's probably true for the lower EFI scores where there's significant abnormality in the structures. But when you look at the higher EFI scores, we see that improvement in endometriosis resection for up to 36 months, and that's actually where the study ended. So it's now important that when we do endometriosis surgery for a fertility reason, that we actually be aware of not just staging the disease as according to ASRM staging, but also look at EFI. And this is something we're now starting to do at RPA, and I think something we've been doing privately as well. Backwards. So she had her resection, she had an uncomplicated course. We met up again afterwards to discuss her options. Again, IVF was offered, but also spontaneous intercourse, natural intercourse was offered, and the decision was to try naturally. And really 3 months after the operative therapy, they fell pregnant and they've gone on to have a live birth. So again, this case illustrates the fact that not everything needs IVF. So just to summarize, so clinical assessment is really an important tool, and certainly when you come to RPA for fertility assessment, we do offer a 45-minute first visit where we can actually assess somebody properly in the rooms. I offer them a 1-hour appointment, so I think we do spend a bit of time in the initial assessment. We always need to include a prenatal screen. Investigation should really initially include hormone profile, structural assessment, and a semen analysis. We always say that treatment is targeted to cause, and where there isn't a cause found, we do IVF, but certainly IVF is not always the solution. So that's where I'm ending. Happy to take any questions.
Wow, Ying, that was great. Thank you. There's a few questions on the chat, and I've got a few questions myself as well. But the first question is quite a good question on the chat, which was about the role. You did mention briefly about often using thyroxine replacement, or so as a GP, if we're seeing women who've been trying to get pregnant and they're not getting pregnant, say 6 to 12 months, they've got normal TSH, but they've got positive high thyroid auto antibodies. Would you think it's a reasonable thing for that to be started at a low dose of thyroxine?
Yeah, I think low-dose thyroxine is not harmful. Generally, what we would say at a GP level in somebody who's not yet considering IVF, if the TSH is over 4.5, we would certainly consider starting a low dose. The presence of autoimmune antibodies is controversial, and we generally say we correlate that with TSH. If they have thyroid antibodies and the TSH actually good, it's below 4.5 or below 2.5 really, then we don't think starting TSH has any improvement. Now, where it gets controversial is between 2.5 and 4.5. And really the guidelines and all the research sort of contradict each other, but we've come to the conclusion, and this is after much debate, that in a couple who has normal T3, T4 with a TSH of 2.5 or 4.5 who want to continue to try naturally, then thyroxine is not recommended. If, however, they are moving to IVF, then the guidelines say in order to optimize implantation, then they would recommend getting the TSH below 2.5, even if the T3 and T4 is normal.
Okay, that's great. That's the first ever sort of clear things I've heard about that. Yeah, and yeah. You did mention about ovulation tracking and doing bloods to track ovulation. I've always thought we used to use ultrasound to kind of track ovulation, but so, I mean, obviously, blood testing is probably easier remotely.
Yeah.
So, yeah.
So you can use ultrasounds to track ovulation, and you do that by just measuring a follicle and see where there is. But actually, all ultrasound can tell you is whether there is a follicle, but you can't really tell you when that follicle is going to erupt. So we actually find blood tests much more helpful than ultrasounds. And sometimes if the blood test is a little bit equivocal, or for example, the hormones start to plateau, that's when we can do an ultrasound and say, hey, what's going on with the follicles? I think from an accessibility perspective and also sort of getting bulk billing happening, I think certainly blood works for us. And if you sort of go, interestingly, it's weird because RPA as a public unit won't do ovulation tracking for bulk bill, whereas the private units will bulk bill ovulation tracking. And really all it needs is a GP referral. All of these guys have forms on their websites, and most of them will do 2 to 3 cycles bulk billed.
Yeah. A quick question about oil flushes and hycosis and relationship to fertilities after having a hycosis procedure done with saline or with an oil.
Yeah, so there is one trial published in the New England Journal of Medicine that shows that if you flush the fallopian tubes with Lepidol, which is the poppy seed oil, regardless of what treatment these guys have in the future afterwards, their ongoing pregnancy rates are increased. That is one trial. And a lot of the flushing then has been based on this trial. It certainly doesn't segregate according to subtypes and groups and what type of treatment and also their baseline characteristics. I certainly do offer it in people who really don't want anything done apart from the least invasive. I say, well, have a Lepidol flush. The issue with Lepidol flushing, and there is actually a subspecialist, a CREI consensus on this. They're called ACCEPT guidelines. There's a bunch of them on endometriosis, fibroids. There's one coming out that we've just finished on recurrent pregnancy loss. But there is one on Lepidol flushing. There are 2 issues that we have with Lepidol, and they're not real issues, but things to be aware of. One is that sometimes they do get embedded in tissue, the Lepidol fluids, and they cause a chronic granulomatous inflammation, which can be difficult to eradicate. And the second is Lepidol is really iodine rich. And you really should be monitoring thyroid function after Lepidol for up to a year. We see thyroid dysfunction after this intense injection of iodine, and they can go from anywhere to hyperthyroid to really hypothyroid as a downswing afterwards. So we do say if you do it, monitor it for at least 6 months. So every month a TFT if they're trying to fall pregnant, and treat if they fall outside the parameters. Ideally, some must monitor for 12 months. But it is easy to do. Saline flushing, there's no evidence that improves fertility. And we extrapolate that study on Lepidol to doing Lepidol flushing at hycosis as well. But there's actually no studies on hycosis versus and Lepidol.
Oh, wow. Okay. That's very interesting. I did not know that. Okay. Well, I think we may have to wrap it up. We've got a few more questions, but we'll just have to leave it there. But thank you so much. That's been super interesting, and you covered lots and lots of different areas of fertility. Yeah.
And if anybody wants to refer patients to the RPA public clinic, feel free to do so. It's on the website. We can do an e-referral or a fax. We're happy to see patients.
Terrific. All right. Thanks so much. That's great, Ying.
Thank you so much, Rebecca, for facilitating tonight, and obviously to Associate Professor Ross and Dr. Li for their presentations. They're very comprehensive, and I hope the GPs in attendance got a lot out of it. And obviously thank you to all the GPs that attended as well. I'm just about to send out the evaluation survey via email, so I'd really appreciate your feedback and ongoing support. And thank you for your time. Have a good night. Thank you.
Thanks, Lauren.